Today we are going to present you a very important topic, that is the preventing the first DFU, that is diabetic foot ulcer, a challenge in resource poor settings. So I think people usually discuss about such things where there is no any resource limitation, but this is something unique. So I also welcome Dr. Bijay Patni. He has just joined. So this is then if Dr. Patni is here. So welcome Dr. Patni. Dr. Our today's speaker, Dr. Sunil Vasudev Kari. Uh, Madam is from
Hi, Dr.
Aarathy,
Kari.
Kari,
Namaste,
yeah,
sir.
Kannan,
Namaste.
and here is our
Uh,
very dynamic Dr. R.K. Modi. So Dr. The slide PPT will be CV PPT will be displayed. Dr. Bijay Patni, I request you to kindly introduce our moderators today, and then Dr. R.K. Modi will be take care for to introduce the speaker. Yeah.
welcome, good evening to this USB CME program, our usual monthly program. And welcome, Dr. Aarti, Dr. Modi, and Dr. Kari.
Yes, sir.
So, Dr. Sandip is a chief consultant diabetologist and podiatrist at Cuttack. He's the chairman-elect of RSSDA Odisha, and he has numerous awards and honors to his name at a publication of a chapter in API Handbook of Medicine as well. And Dr. Aarathy, welcome. And Dr. Aarathy is a postgraduate teacher in medicine for past 14 years, national faculty in EPICON and various other organizations. She has been the faculty at our DRWA 2026 as well. Scientific committee chair, okay, Dr. Modi. It's okay. Yes, she has numerous accolades to her name. So welcome, Dr. Aarathy.
Thank you, sir.
And next, Dr. R.K. Modi, boss, you are well known. He is a director of Modi Diabetes Research Center, Purnea, faculty council member, API governing body, chairman, other lots and lots of awards and honors. So welcome, Dr. Modi. We will be taking all the expert comments to our today's speaker's address and presentation. Dr. Kari.
Good evening, everybody. A very warm good evening to you all the dignitaries and all participants, all attendants. So today's topic is very interesting and is a very common topic, that is preventing first diabetic foot ulcer, which is really a greater challenge in a resource poor setting like in India, in district level, in village level. It is really challenging to prevent a diabetic foot ulcer. And for this, we have a very renowned speaker, Dr. Sunil Vasudev Kari. He's a senior consultant diabetic and diabetic foot surgeon, head of department of diabetic limb salvage, chief diabetic foot salvage team, consultant diabetic foot and ankle biomechanics, consultant diabetic footwear designing, and is director Mandakini Medi Engineering Health Private Committees. And he has many professional membership of IMA, Association of Surgeons of India, academic member RSSDI, Asia Pacific Diabetic Limb Problem Association, and so many Diabetic Foot Society of India, Venous Association of India. So welcome, Dr. Sunil Vasudev, sir. And now I'll request you to start your deliberation, which is really a very fruitful and a very interesting topic. So over to you, Dr. Kari.
Thank you, sir. Let me share my presentation. At the outset, let me thank the Dr. Engg Singh, sir, then entire team of CME India and the moderators who have been very keen to know about foot ulcers, which has become a major problem across India, across globe. So preventing first foot ulcer in diabetes, which I thought that it should be discussed in detail, because the first concept on diabetic foot conference was conducted in 1986 in Melbourne. They first saw this problem, why the diabetic people are getting these foot ulcers, and they started working on it. Until now, it is just 50 years now work up. But in last 50 years, we have been working more on healing the ulcer rather than preventing the first foot ulcer. And looking at the scenario, the way the first foot ulcer gets into next level, and we try to heal it in 100 days or sometimes 120 days, and then it is healed, and the moment the patient starts walking, he comes back with the recurrent ulcer. So this is a segment which has to be addressed by diabetologist, by endocrinologist, by every family physician, how best he can prevent the first ulcer. Because I'll show you what are the basic things in rural India. And a patient when he's poor, and genuinely in rural segment, the number has increased drastically. And we are seeing now the first ulcer in the forefoot region, which has become very common. 80% of the rural areas are coming with this, and they are also coming with midfoot and hindfoot ulcers. And in days to come, in next 10 years, the awareness gradually it is increasing regarding the ulcer and management. And every diabetic who comes to me, he keeps on asking, sir, look at my feet and predict the risk of amputation. This is going to be a slogan, or this is going to be a request from every diabetic, whoever comes to our clinic in days to come. Now, it is a time to act on foot care, which is very, very important that everyone has to be working on how best we can start taking care of the feet to prevent the first ulcer. So, strategies, considerations for managing diabetic foot care in low resource setting has to be a major concern from guidelines, protocols which has been designed by RSSDI in every year. So we have to take low resource settings as a consideration, how best doctors, healthcare workers who are working in those areas in rural setups, they can still prevent the first ulcer with minimum requirements. Whatever research and whatever statistics we have been seeing in the last 50 years, the diabetic foot ulcer has been life risk if it gets infected, or it is a limb risk. Many of the patients are losing the limbs. As all of us know, what exactly statistics, the prevalence, as all of us know that 537 million adults in 2021, which is going to be 783 million by 2045. And if I look at India, now the urban has reached 30 to 40% diabetic. Rural equally it is increasing because of change in lifestyle. So rural segment has to be taken into consideration. And as complications of diabetes, all of us are quite aware of cardiovascular, neuropathy, kidney damage, retinopathy, and foot ulcers. They are significantly impacting the quality of life and increasing the morbidity rates. All of us know that DFU is common, is complex, and it's very costly. Even at rural level, they have to be very meticulous in taking care of the feet. Now, if you look at the data from Armstrong, every 1.2 seconds, someone develops a diabetic foot ulcer. If that is the case, every minute there is 50, and every hour there are 300 ulcers, DFUs are getting ready across the globe. It is complex indeed, because the level of challenge what we are seeing in last 25 plus years, the way I am seeing exclusively working on this area. Initially, I used to have one limb, and now gradually I am seeing multiple bilateral diabetic foot presentations. Now I'm seeing in my clinic the diabetic foot ulcer with PNP, with PVD, with CKD, with retinopathy, with all comorbid conditions. And it's really, really a challenge to treat all these level of comorbid conditions coming up with ulcers, and patients are finding it very difficult to heal it. And level of skill, the doctor who is handling these cases, he has to take care of so many variables and work on it, and the outcomes are really, really question mark. We are unable to give them a hope that this is going to get cured in 100 days, because there are so many parameters which are working on healing of the DFU. Now, looking at the CPR score of every physician, as every physician has his own CPR score, everyone cares for the feet, everyone tries to protect it, but there is delay in reference. That delay leads to such a cost, which leads to highest morbidity and mortality. Even patient may lose a limb, but this delay has to be taken care of, wherein a very high risk feet, or we have to prevent the first ulcer to curtail all these complications in diabetic patients. Now let us go through the diabetic foot facts. 80% of the people with diabetes are from low and middle income nations. Every 7 seconds, someone dies from diabetes. Every 20 seconds, someone is amputated. If you look at Indian figures, we don't have a registry yet, but it looks like more than 1 lakh per year. The lifetime risk of a people with diabetes to develop a foot ulcer is almost, it has reached up to 34%. More than 50% of diabetic foot ulcers become infected. One third of patients seeking care of ischemic wounds will die with an unhealed wound. Most of the PVD, CLT, especially after Corona, the way we are receiving in tertiary in my center, a lot of patients are having this PVD, CLTI, and acute limb-threatening ischemias. Diabetic foot ulcers double the mortality and heart attack risk while increasing the risk for stroke by 40%. More than half of those with healed osteomyelitis will undergo high level of amputations. This is a very, very interesting what I got the facts. Looking at the years lived with a disability, if you look at the number one stands in WHO global burden of a disease is back pain. But the 10th is ranked as diabetes related lower extremity complications. Now, if we medical fraternity is unable to handle this situation in next coming 10 years, it may reach in higher number 1, 2, 3, 4, 5 in very speed way, so that the disability is going to increase in days to come. Now, what exactly happens with the doctors community? Look at the presentations, the varieties of diseases: ulcer, heart failure, cancer, COPD. We have got 15 varieties of diseases. And out of that, it is maximum we have seen DFU admissions of 3.8, greater risk of admission. 92% more outpatient visits per year has been noted by Armstrong, and 44% more time is spent per visit by a doctor. So this is going to be a big, big burden, and in days to come, we have to tackle this problem. And all of you are aware, relative 5-year mortality gradually as highest is pancreatic CA, lung CA. But look at now, immediately the third position is peripheral arterial disease and amputation and ulcer and neuropathy. These are the 4 which are gradually reaching to the highest level. Diabetes, the moment day 1 you are diagnosed, everyone is afraid that you are going to end up with amputation. Is it a single step? Can we prevent it? It is not a single step. It has got a stairway of amputation. There are totally 5 steps: normal DF care, PNP PVD care, DFU care, DFI care, and the big, big burden which is coming in last 20 years, the way I am receiving, is rehabilitation care. Many have lost their limbs unilateral, and they are asking me in my clinic, sir, please try to save the other limb, where they have an ulcer and they want to heal that ulcer. So this is going to be a big burden in days to come. Impact of a foot ulcer on health and quality of life. Understanding the profound effect of foot ulcer on diabetic patient reveals the urgency of prevention strategies we need to work on. The number one, 30% of patients report significant psychological distress due to foot ulcers. Number two, 60% of diabetic patients with foot ulcers experience severe morbidity. 80% of the foot ulcers lead to lower limb amputations within 5 years. 1.5, higher mortality rate among patients with foot ulcers compared with those without. These 70% to 80% can be preventable with proper care and education. We can definitely bank on how best we can reduce these first ulcer. Now, let us go with why I selected this topic. I have explained you because it's going to be a big burden in days to come. Now, if I go to the basics, why it happens, understanding the foot ulcer in diabetic patients. So if I go the ambulation, the first step, if I go to the video, and take off. Tire load 6 times is there on the forefoot. If you can see once again, or the other one I'll show you from the posterior view. That the heel strike, stance, and maximum load on the forefoot. So whatever we see in day-to-day life, in daily practice, 80% of the forefoot ulcers are seen because the takeoff takes maximum weight of the body, and where it is insensate and the area to take that load is fixed at particular point, and there is callus and there is ulceration. This is the most common pathway of diabetic ulcer, which I have been referring since past 20, 25 years. The Reber and the colleagues made it so clear. Neuropathy is a baseline pathology, deformity is a pathophysiology, and minor trauma is an environmental event. This is how accumulation of component causes to form a sufficient cause, there is a time, and it ends up with an ulcer the moment it gets completed. So, as a physician, as a healthcare worker, how best I can take care of this neuropathy? And neuropathy, as all of us know, that the excellent care of a blood sugar is a criteria where you can postpone the events. The deformity, pathophysiology can also be taken care of by corrections, but minor trauma, either it could be inside out trauma or outside in trauma, which has to be taken care of, and the time, which is very, very important, where we don't allow all these three to meet at one point, then the ulcer can be prevented. The factors which contribute to pressure as a concern for the ulceration due to diabetes, they have a neuropathy, they end up with high pressure zones. The stride length makes a difference, the cadence makes the difference, ground contact time, if it increases, they end up with ulceration. Walking cycle, as all of us know, that it is 0.8 second. If it increases more than that, then there is always chance of having an ulceration. Load against gravity. Anybody climbing upstairs many a times in a day, that makes a big difference for the insensate feet. Bony architecture, muscles and tendons as they lose the nerves, uh, all the nerve supply. Fat pad cushions which are there on the forefoot, metatarsal pad of fats, heel cushions, which get totally thinned out or pushed forward or pushed backward. All these end up in ulcerations. Especially joints, which have got limited joint mobility, they become more and more rigid. So barefoot walk and poor fit shoes. So as I made it three categories, 1 and 2 are responsible for inside out injuries. The bony segment hits the ground and breaks the feet. And the number 3, barefoot walking and poor fit shoes, is outside in injuries which lead to ulceration, first ulcerations. Now, if I want to define the viable foot, biomechanically viable foot, and how in India all these diabetic feet are safe, happy, cared, protected, and are they functional? All of us know that it is an organ of ambulation, and we categorize them as low risk or high risk. But is it biomechanically viable to stand, to walk, to jog, to run? So this has to be taken into consideration because entire biomechanics gets altered because of sensory neuropathy, motor neuropathy, autonomic neuropathy. The foot ends up insensate, rigid. It is not flexible at all. Non-functional. Many a times we have been seeing non-ulcerative foot problems, shortcut foot, where you have a fractures without any accidents, without any trauma. The patient is unable to hold his own body weight on his feet. The tarsal bones get fractured. The metatarsal have got fractures. We have seen fractures in phalanx. Many things happen in these diabetic patients because of pan neuropathy. Now, as all of us know, international working guidelines on diabetic foot, the guidance has started since 1996, and already we have a latest guidance from 2023, which has included CKD as straightaway high risk feet. We need to understand there is one more group, very high risk, and that has to be addressed in Indian scenario, especially in rural segment of India, because 80% of rural India is barefoot. If at all I try to convey them that you should wear a footwear, they always opt for a worn-out footwear, and that is also a cause for ulceration. The lifetime risk for a diabetic, as all of you know, it is more than 34 now. Yearly incidence rate is increasing, it is 2%. All these guidances have been graded as recommendations are strong, quality of evidence is high. Accordingly, all these points have been kept into the guidance. But has screening of a foot reduced or prevented the first ulcer? Has to be addressed. There is no much of an evidence on that. How frequently we have to take care of very low, low, moderate, and high risk feet? That frequency also is not having any kind of evidences. It has been broadly placed yearly, every 6 months, every third month, and monthly for the high. But many a times the outcomes are altogether different after following all these guidelines since past 50 years. What we did, what didn't work in last 50 years? We were unable, entire globe is unable to prevent the first ulcer. Healing of an ulcer, yes, by so many measures, reaching within 100 days, 120 days, we have achieved it. But prevention of the recurrence, again, miserably, we have been failing at a rural segment by many of the doctors because there is awareness which is lacking regarding offloading, offloading, and offloading. So, what should be the module? What care module has to be planned? The care module is primary care, secondary, and tertiary care. And both these segment, primary to tertiary, footwear care is very, very important, which is missing in tertiary in the rural segment, and exercise care, which is very, very important, which most of the rural segment people are not at all aware. They keep on moving in the fields. They have their own approach to reduce the sugar levels. They don't take care of the feet. Barefoot, they keep on walking and they end up with ulceration. Now, if pressure is the only cause for ulceration, no. It is more relevant than only high pressure is impulse loading, the product of pressure and ground contact time. Any patient who is having pan neuropathy, massive sensory neuropathy, standing for a long duration, or there is a ground contact time has increased during his gait cycle, he is going to end up with ulceration. There is going to be mobility, especially a patient who is having restricted first MTP joint mobility is going to end up with first MTP joint ulcer. And anybody having dorsiflexion rigidity is unable to dorsiflex his feet at the ankle joint, he is going to end up with ulcerations at the forefoot. Normally, what we have read in all our medical curriculum is regarding normal foot, which has got intact nerve supply, intact blood supply, intact immune system. But nothing has been written on compromised foot behavior in diabetes. In diabetes, there is a neuropathy, there is a vasculopathy, there is immunopathy. So every foot looks basically normal the day when he's diabetic. Gradually, he ends up with callosities, then ulcerations, ends up with chronicity as a chronic ulcer, and then gangrene. This is how a compromised foot behaves in a diabetes if it is not taken care in a early phases. And the basic problem in rural segment is they don't appreciate pain here. There is no pain at all. It is insensate. So the concept in rural segment is whichever disease has got maximum pain has to be taken care of. If it is painless, then need not have to worry because it heals on its own. That is how most of the patients who come to me from rural segment, they keep on telling me, doctor, why are you taking so much care of these ulcers when they are not at all hurting me? They don't have any issue. I don't have any issue with them. But you have been guiding me with footwear, you have been asking me to do dressings, you have asking me to offload, not to walk too much. So all these areas of awareness has to be brought in rural segment, otherwise they are ending up with maximum amputations. When it comes to exercise as a guidance, I have been seeing many diabetologists, healthcare workers have been guiding every patient to control the sugar they have to walk. Now, what is the evidence that the foot is absolutely normal to walk for 1,000 steps, 5,000 steps. You have to have an X-ray, bony architecture assessment, and then only it can be advised that this is low risk feet, this is medium risk feet, and this is high risk feet after going through all the neuropathy assessment, bony assessment. Otherwise, the moment you start walking, there is always a area which gets inflamed and it heats up and then breaks. So it's very, very important that food treated for ulcer, infection, and Charcot need not be advised exercise to control the sugars. And that has led to a major problem for me in a rural segment to guide them to come out of this exercise if they have a massive neuropathy with bony architecture deformities. Number two, they have already ulcer, still they want to walk and the ulcer is not healing and they end up with infection and there is a DFW created. They have lost some of the toes and still they are very keen during healing process. They want to do exercise. And shortcut foot where there is enough damage is done, acute and chronic, still the exercise, this knowledge is down the lane, has to be taken out. Awareness has to be brought in a bigger way in rural segment. Now, footwear as a cause for diabetic foot ulcer, where first ulcer I have seen in rural segment due to footwear. So you can see in outer sole all these pricks, the worn out footwear. Many of them have kept the socks inside the shoe and they don't appreciate. There is no space for them. They never put hand inside the shoe and check any foreign material or anything. They have left the socks and they just push their foot inside and they end up with forefoot ulcerations. And this is very bad the way they have been coming to me. Look at the insole which is torn out and unscientific way of offloading which they have been practicing with some of the local guidance and they end up with ulceration. There is a seam. Footwear has to be without seam. Seamless footwear is a must. Wear is also important. What kind of wear they are doing. Not too loose, not too tight, and barefoot. All these are causes for the first ulcer in a rural segment. I'll just give you an example how these people are coming to me. Toes strap, chappals hold, they end up with such kind of first ulcerations. This is the first ulcer which I got it from a rural man who was using such kind of a sandal which had a strap, which never had a good heel counter. And this was a shoe which for a function the rural person was using it, which is a narrow forefoot area, and that led to the little toe gangrene. And this is what commonly we do it during our younger days, using father's or mother's footwear and wearing it right on the left, left on the right. But this I've been seeing in my clinic. If you ask a patient to wear his own footwear right in front of you, he wears right footwear into the left, left into the right. And this is a cause for the ulcerations. Now, how best prevention in these areas we have been practicing? Trimming of a abundant callus is the first step, which has been taken care of. Everyone is doing it. Avoiding weight-bearing exercises is a priority. Avoid barefoot walking. Socks are not protections. Worn out socks are still having a lot of problem. They will end up with friction injuries and ulcerations. They are not protective at all. We have many of us are using now temple socks, which they are having insole inside and outer sole is also there in the socks. They can use it. Customize adequately fitting footwear is a priority now. And whatever now diabetic footwear, as all of us are very well aware, there has to be a good padded tongue, extra depth, firm heel counter, padding around the ankle, roomy toe box, and seamless and good, strong outer sole. These are the priorities which we are trying to give it to the people who are suffering from it and trying to work on claw, hammer, and mallet toes, where we try to make them biomechanically viable by correcting it by tenotomies, and that can prevent the first ulcers. Challenges the way we are facing in the resourceful clinics is number one, limited medical supply availability, shortage of trained healthcare staff, lack of patient education resources, inadequate infrastructure for care, financial constraints impacting services. Preventive strategies for foot ulcer development. Implementing effective preventive measures is crucial in resource-poor clinics to reduce the incidence of foot ulcers in diabetic patients. Regular foot examination is a mandatory, which we have started working on it. Proper footwear advice, and to prevent the injuries and pressure points, frequent every third month, we ask them to change the footwear. The moment the insole, whatever size 9 mm, reduces to 4.5 mm, then ask them to change the insole or change the footwear. Patient education, patient relation education, we have made it mandatory in our setup, wherein that takes care of most of the first ulcer injuries. Monitoring and follow-up, which is missed in most of the areas due to rural segment, they never bother for regular follow-ups, and that has led to major problem, and we have to reinforce these preventive strategies by regular follow-up. Community engagements. We have been going ahead with school teachers, especially Gram Panchayat level. We have been bringing up school teachers or local leaders to bring up the awareness regarding what exactly awareness has to be provided to support for foot care in diabetes for all those areas. Role of education and awareness. Positive outcomes with education programs are there, and challenges in non-educational settings, higher rates of ulcers we have seen, high risk factors, preventive measures, delayed treatment, they end up with amputations. Collaborative care approaches, understanding the essential stages of collaboration among patients, healthcare providers, community resources to prevent foot ulcers in diabetes has made a big difference. We have engaged actively patients participating in their care and accountability of the healthcare outcomes. Assessment, we have taken care of educating patient and providers has made a big difference. Resource utilizations of community resources, we have made it available for them. Follow-up, we have asked him to be more regular, and that has led to a case study successful prevention in resource limited settings, which I can tell you, highlighting effective interventions for preventing foot ulcers in diabetic patients within resource poor clinics too. In 2015, a clinic in rural India implemented a foot care education program resulting in 40% reduction in foot ulcers incidence. In Africa in 2017, it has reduced 50% decrease. And in 2019, a Latin American has brought 60% reduction. So in conclusion and recommendations, preventing first foot ulcer in diabetic patient is critical, especially in resource poor clinics where the challenges such as limited supplies and inadequate training exist. Implementing proactive strategies, including education, regular checkups, and community involvement, can significantly reduce the incidence of foot ulcers and improve patient outcomes. We have been working on these areas. We have been addressing all the district DHO wherein he is handling not more than 100 to 120 Gram Panchayat PHCs under his belt, and we address all these medical officers, ASHA care workers, healthcare inspectors, just to bring an awareness regarding ulcers in the diabetic foot, how best they can take care when they reach to individual houses and those who are diabetic, what best precautions or care they have to take regarding foot as well as footwear. So we keep on working on this area that has brought a big difference. And I would like to know from all these uh, eminent moderators, Dr. N.K. Singh sir, then many of the expert persons who are there in this webinar, do guide us what all can be added up and which can be brought as a guidance at level of rural segment. Rural healthcare worker should get a sufficient support by which he can try to prevent the first ulcer. Thank you so much.
Thank you, sir. I think this was a fantastic lecture. So, Dr. R.K. Modi, can you comment on the first reaction on this his topic and his talk?
Yeah.
Can I stop sharing, sir?
Yes, sir. Yes, sir. Yes, sir.
Yes.
Uh, yeah. Dr. Sunil Kari, very practical, and you explained all practical. Really, you are a very experienced foot surgeon, and you have seen many cases of diabetic foot ulcer. I must congratulate you. It was an excellent deliberation, and in my view, this preventing of first diabetic foot ulcer is primary prevention, isn't it? It is just like primary prevention, and we know the recurrence rate. Definitely, there are 40% recurrence rate, and most of the time it is silent. You have very nicely described that for a compromised foot, which looks normal as a normal foot, but they have neuropathy, they have vasculopathy, and if they get a trauma, they may get an ulcer. So this is a great challenge, especially in resource poor setting like in India. And in my view, this prevention is really most cost-effective intervention. And for this, education it should be kept on top, because when a patient of diabetes comes in a physician's chamber, we describe them many things, and we describe how to prevent a foot ulcer. This should be one of the major thing in the patient education when he comes first time in our clinic. So diabetic education is the cheapest and very effective mode of prevention of first diabetic foot ulcer. And this education, you have very nicely described that in education, first we have to educate ourselves. We all clinicians or healthcare persons, they should properly know how to take care of a diabetic foot. Then patient education, that comes on second. Thirdly, we should train our paramedical staffs, our compounders. We should also teach the family members how to take care of a diabetic patient's foot. Then, of course, there should be community participation, as Dr. Kari has nicely described, that healthcare workers and ASHA workers, they can also spread this education part of a diabetic patient. So one thing I think that is very important, and that is from our part, that we should identify high-risk foot. That is very important. So identifying a high-risk foot, confirming one question I just saw in chat box, is simple monofilament can declare is a diabetic foot. No, only simple monofilament test with one additional test like pinprick sensation, or we do it from our hammer demonstration of reduced ankle jerk. Two tests, they confirm high risk foot. So this is my take, and I invite other moderator to say their views.
I just want to add on one more point, sir. After going through so many modalities to prevent the first foot ulcer, one of the country just made it a point to ask a questionnaire to all the diabetic patients who are attending pharmacy to buy a medicine. The pharmacist will give the medicine after asking the questions whether he appreciates the foot grip or he loses the footwear. There is no, वो बोल देते कि मेरे पाँव में वो फुटवेयर रुकता नहीं सर, अपने आप निकल जाता है. This is a basic question which the pharmacist is taking note of it, and they could make up, and that list has made up a big prevention of the first ulcer, where most of the time the diabetologists, the endocrinologists, the number is increasing every day. They are seeing 100, 200 patients, and they are unable to go in details of these. And that job has been given to the pharmacist, and he records them and sends those details to the concerned doctor who has asked for to get these medicines. That has made a big difference in preventing the first ulcer. This was something interesting paper which I read it. Then second, most of the time I have been seeing how many physicians are allowing footwear to get inside their chamber and visualize it, that whether that footwear is ideal, it is off the shelf, is it a diabetic footwear, what exactly is using. Nobody is trying. It is diabetic footwear which gives 80% of the whatever is happening in the foot. Foot doesn't know what to do in diabetes. It is the footwear which has to do the job of foot. So many a times I have seen many doctors, they don't allow footwear to get inside the chamber, which has to be changed now. Which has to be changed, and many things have to be adopted in a different way.
Yeah, now I request Madam Kannan to give you her comments.
Yeah, good evening, sir. And first of all, thank you very much for this opportunity, sir, to be a part of this CME webinar today. And thank you for choosing me to be a part of this diabetic foot ulcer, prevention of diabetic foot ulcer in a resource low poor setting, sir. Actually, we are from a very rural place near Kanyakumari, where we have awareness about this diabetic foot is very, very low still, sir. So educating our patients, asking them to do so many things really makes the patient not come back to us actually. So this is a very devastating complication which we are not able to prevent at all. They come to us with a lot of complications. The ulcer has developed only after that they come to us because they are either the toe is black or the leg itself is black. Only then they say we were busy, we couldn't come, because the most of them will be tree climbers or they'll be going to the sea to catch fish. So most of the people here of that category, they do not take care of their sugar levels at all, sir. So even if we try to promote an education to them, we're not able to promote it to them at all. So if you could give us something that you can tell us how we are going to educate these people, get hold of them to prevent the first ulcer, it'll be a very, very big thing. And asking them to buy a diabetic foot, a personalized diabetic footwear is another big issue that we are facing, sir. Though government is there taking care of the foot, there is nobody to tell how we are going to prevent the first diabetic foot ulcer. So thank you so much, sir.
This issue has been there everywhere. Not
Yes,
only
sir.
at Kanyakumari, across India.
Yeah.
No, see, 80% of the rural area, they are barefoot.
Yeah.
And that barefoot itself is a big issue for us. And if at all I shout at them, next time the same patient comes to me, and when I ask him to show the footwear, it's a worn out footwear. And that is also a
Yeah.
cause for the ulceration.
And
He
even if
comes
we
to
tell
me,
them to
"Sir, आप गाली देती है, इसलिए मैं पहन के आया."
even if we tell them to come in with a footwear into the OP, they say, no, it's not, they take it as a chance that it is not like we are not giving respect to you. They speak like that. Say, no. So we have to go out and have a look at the shoes for that.
Yeah,
So,
exactly.
We are coming out with all these solutions now. They have to reach to us to bring up the knowledge about footwear. So what we are now coming up with one app which I'll be sharing with Dr. N.K. Singh sir. That this app which I have developed, anybody from anywhere, which I was working on it during Corona, where I reached to them, where they were quite miles away, 400, 500 kilometers away, they were sharing the photographs. I have told them what photographs you have to share regarding the foot and footwear. And we could tell them that you are heading towards disaster. You have to take these cares. So this can make a big difference. Even if they are not reaching to us, we are giving this app to our ASHA care workers, to healthcare inspectors, and the person who is working in PHC as a medical officer, because they are not having time to take details. Even just photograph of the feet, where we have developed one new dynamic view. That view can give us whether this foot is going to break, number one. Number two, if somebody had an ulcer and underwent an amputation of a toe or second toe, whether he is going to have a next ulcer, recurrence is going to be there, that also can be told with this dynamic view. So all these things, newer things, we are trying to reach to the rural segment by and every rural person is with mobile now. They are having mobile, so they can very well share their foot photographs and footwear photographs, and I reach to them, which I think I'm going to show this in 26, which sir has asked me to deliver it on Bombay CID 26, which this is something new. We are trying to prevent the first ulcer by taking the photographs. And in my clinic, before patient comes to me, his footwear photograph has to reach me, and his foot photograph. My staff has been trained first to do that, and then the patient comes to me. Then only I think things go in a different direction.
Yeah, exactly, sir. So Dr. Sandip Mishra, are you there? Yeah, Dr. Sandip. Dr. Sandip, are you there? Yes, sir. There was some medical issue with you, I think. Anyway, yeah. So let us take first one comment from Dr. Mishra. Yeah. Then Dr. Modi. Yeah, unmute yourself. Unmute yourself. Dr. Mishra, unmute yourself. You are muted. Yeah, now.
Yeah.
Now you
Sir. Good evening and Jai Jagannath from the land of Lord Jagannath. And I have already heard Dr. Sunil sir and others. Sir, my suggestion to prevent the first ulceration is beginning from the patient himself and the primary care physician. Before, if they come to a diabetologist, usually they suggest they take suggestion of primary care physicians. So primary care physicians should be educated first, and the patient should be educated for self-examination of food. And in the waiting area, we need to display some self-examination of food photographs so that patient can learn from that, and if any doubt persists, they can clarify with the physician himself. Second thing is, each clinic, in my suggestion, what I am doing, there should be one tray to keep their footwear. What already Sunil sir has mentioned, and Aarathy madam told that they feel some disrespect to the doctor visiting doctor, so that they are taking footwear with them to the clinic. So we can ask them to put their footwear on a tray and bring it to show the doctor. And from the wear and tear and the high pressure area marks on the footwear, we can diagnose early, even before the setting of any ulcer and any sophisticated investigation, that these are the high pressure point areas, and you are using a footwear which is already damaged. Most of us, they don't know that lifespan of a footwear is hardly 6 months. Beyond that, using a footwear, it causes more harm than good. So that is the second thing. And third thing is to let them know that footwear should be roomy, should be comfortable, and before buying a footwear, they should know that what is the time to buy the footwear. Usually whole day they are putting their leg down, and in the evening the foot attains its maximum size, even though some swellings are there. So it is the best time that the evening hour you should go to the footwear shoe shop, and you can buy a shoe which is well fit at that particular point of time. And before using the footwear, they should examine the footwear whether there is any foreign bodies, any sort of insects there or not. And these are the few things which mostly patients miss, and in a hurry they are using the footwear. Inside that some pebble may be there, some nail may be there, some insect may be there. They will bite them, and it will cause some sort of trauma, and that will aggravate further. So few small things which are to be taken care, and they should be we should create some awareness among the patients that these are the few things which you should do at your place, and let us know at the first point if you mark any sort of color change, temperature change, or any abnormal wear and tear in your footwear. That should be brought to the notice of the physician, so that they can advise some special investigations to prevent them further.
Thank you. I thought Dr. Modi.
Yeah. Yes, sir. I totally agree with Dr. Mishra. And what I do, that is my practical thing, what table where I write prescription. So the patient, they becomes very curious, why you are putting a footwear on your table. So I tell them, see, this is very important. Your foot is very important, and you should have a footwear like this. This is diabetic footwear. That is one way I practice in my clinic. But my question is to Dr. Sunil Kari, that we face big practical problem, patients coming from village, and we know India is also a land of villages. So what problem in the farmers, especially in paddy season, they have to do sowing of the paddy, dhan ropni, we say dhan ropni. They have to go in mud and they sow the paddy plants, small plants. So they have to go barefoot in that. And when we ask them, you should not go barefoot, you should you use some footwear, so they really laugh. So what is the problem for them, and how we can make them to understand that even going in mud may cause.
See, basically, how we look at this issue is this has been a common problem across India. Am I audible? Hello?
You are audible, yeah.
Yeah. See, this is a common problem across India. Every farmer has to enter his field, and he never goes with the footwear. So naturally, but one thing what we have noticed is whenever he is going without footwear also, when he has been told that any kind of a prick, any kind of even stone or nail prick or thorn prick is going to make a big difference, because he's not going to appreciate any kind of pain in that area. So we have been telling him that footwear, if you use it, whatever the prick is there, you are not going to appreciate. You may lose the footwear because most of the diabetic footwears, they don't have water resistance, which the way we are the footwears available here. But in due course of time, if he makes up a mind to go for woodland footwears, which we have been using it and we are regularly giving it to some of the farmers, which are above ankle, they are having just above ankle hold, where they don't have triplanar motion at all. In a regular sandals or a simple shoe which is below ankle, they have a triplanar motion of the ankle, which can lead to more damage when they are entering into field where it is totally with water, mud, and a lot of issues. But when they go with something what you carry with military shoes or with something which is holding above the ankle, that makes a big difference. Many of them have opted it. Some farmers have spent on it because it has got a good outer sole, which is very thick, very rigid, which doesn't allow any penetration of the sharp stones or nails or any kind of the thorns, and that has helped them. But this is going to be a major issue with our farmers when they start getting into the field. The one more question was asked here by Pratik Chopra sir, that temples, especially near, I think in most of the temples near Bangalore, I think they have said that they are not allowing it the footwear. But we have temple socks, which is readily available, which is outer sole. It is just like a socks, which has got outer sole, and inside there is a insole which is placed. All diabetic devotees can very well wear the temple socks and enter the temple. Temples are not objecting for socks; they are objecting for the shoes. So that can be used. I think there was a question by Sir also, NKC Sir, that
Yeah. So
control of
this
sugar.
question was, yeah, Dr. Kari, this question was by Dr. Mohan. Mr. Pradeep Chopra is our technical person.
Acha, acha, acha. So, Mohan sir, I think there is a temple socks which is readily available. We have got insole socks also now. A silicone insole has been placed now, which we give them to wear it inside the shoes also, inside house also. So that has made a big difference to prevent the first ulcer. And prevention is possible of the first ulcer by postponing the neuropathy by excellent glycemic control. Yes, that is priority. There are many have been all the most of the thing goes with the glycemic control. If somebody is having excellent glycemic control from day one, he is postponing all these foot events. But if at all, screening makes a difference. With the way we have been receiving screening of the foot for neuropathy, vasculopathy, and most of the pressure points, this is to be practiced at higher center levels, metros. Still, what is the record, what are the papers, what is the evidences in India we are having? Please do share that those who are doing this regularly, they could prevent first ulcer. That makes a big difference, which can be made. Because as I go through so much of research papers, the screening, International Working Group guidelines also has mentioned very clearly, screening of the foot is a must. It is a recommendation, but evidences are very poor. The work is very poor on that area. Most of the patients, like TCC, to heal an ulcer is a must, but nobody is practicing total contact cast. Evidence is very poor, but it is a gold standard, and which I have been recommending to all these resource poor settings. Go for just above ankle TCC. Need not go for nearer to the knee. You can go a TCC, and it can make it 2 halves, anterior slab, posterior slab. Every day you can do dressing, and again put it back, roll it, and don't allow these 27 bones and 52 joints to have any movements at all. Make it totally static. The ulcer heals. But nobody's practicing that. Everyone wants to have higher end footwear, some kind of newer gadgets, which is not helping them at all, where the ulcers are entering into different infection and end up with amputations.
Exactly, sir. So, Dr. Patni, can you see few more questions that was asked by few of the audience which I have posted? If there are relevant questions, you can ask. Dr. Patni, can you see? Unmute yourself. Unmute. Yeah.
Dr. Ajay Gupta has asked, the newest reviews frame diabetic peripheral neuropathy as driven not by single pathway but by mitochondrial dysfunction, endoplasmic reticulum stress, reactive oxygen species downstream of all the classical routes, which matters clinically because it explains why single target drugs have been disappointing. Very good question, I think so, for Dr. Kari. They want a pharmacotherapy for such an event. Is it a monofilament test enough to declare a food? I think probably Dr. Modi has already answered that.
He already answered, yeah.
Yes, and does tight wait are the questions?
Blood glucose prevent the first foot ulcer. So I think this is a very important question. So I think that's Dr. Sunil Kari
So
answered, I think.
before Dr. Sunil Kari starts his answering the question, Dr. Kari, would you agree with me that first and foremost, 50% of our patients are not even aware that they are having high blood glucose? I mean, this is why I'm telling you, because we do camps in the out of Calcutta, a few of the places. And we have realized over the years, we have been doing it at regular intervals, I would say, but the scenario has not changed. Universal screening is the rule, but hardly practiced, number one. Number two is that if you're not even aware that you are having high blood glucose, the second question doesn't even arise that we are in the state of prevention of the first foot ulcer. As you talked about temple socks. Now, how many temples do they really provide socks, whether outside, inside, or wherever it is? Because recently I went for the Kumbh Metacon and I visited about 33 temples. I did not find a single place where the socks were there. So these are practical aspects which need to be actually brought into the notice of the authorities. Because this is a very simple solution and this is very common also. Walking barefoot in temple does hurt the diabetic feet, right? And that is what need to be addressed. Because whatever we know, the farmers have to enter the field. Now, how to prevent them? Do we really provide them the adequate footwear? Will they accept it or not? But before accepting, do they really know about it or not? That is what is important. So we know the policemen wearing the proper boots in the flooded area. The same can be applied to the farmers in the land. But do they really know about it? So these are all the stuff which probably need addressing. So it's very difficult in today's world, in Indian scenario, dealing with such a huge population to prevent the first ulcer and the subsequent recurrent ulcer. Third is even the sole. Are the soles available? As you said, over the it decreases very rapidly. The sole's depth decreases from 9 to 4. Now, are we able to provide the soles to the community as such? At least I could not get a sole in my area from any particular authorized shops. So all these are very important because a proper sole, adequate sole, which can be changed every 6 months, as Dr. Modi said. So those are very important way of prevention. So we need to put certain important aspects into prevention. Now, I think you being a leader in that, you are doing such work in different ways. You have agreed to telemedicine as one of the component. I agree with it. And that should be taken very seriously, that the patient can actually present their photograph or they can share the photograph. At least we can identify at this foot, right? Though it needs a physical examination as well, but at least we can tell them you can come over. But then With such a huge population, probably the outreach program will be more efficient, I think so.
Absolutely agree with you, sir.
Yeah.
Whatever points have been told, the best solution for this is awareness, awareness, and awareness, and which is missing. 80 to 90% wherever I have visited in urban or in rural setup, they are more interested in going in for screening for the foot than asking the real problem with the patient itself. They have been screening for the ulcerated foot too. There is already ulcer, established ulcer, but they are spending more time on all these PNP tests. They want to do, once it is established ulcer, it is straight away in high risk group. In what way this screening for an established ulcer patient makes a difference? The patient at my place once asked me, he never had an ulcer, but he had only one symptom: tingling numbness, severe pain, shooting electrical shock like pain. Then I told him, see, you are going through peripheral neuropathy, and this is how these tests are done, and you are not appreciating them. He said, okay, sir, as you said rightly, they are very true. Give me solution. Then I wrote all the B complex, whatever is required. Immediately after 3 months, he came back to me and he said, sir, please check all those machines. Whether it is
Yeah,
possible
Dr.
to
Kari,
reverse it.
yeah.
He shouted at me. He said, sir, when you know it that it is not going to be reversed, why you are doing it regularly? This is what basic thing. A person who is having ulcer, a person who is having Charcot is getting through all these screening tests. So screening as a foot for the newly detected diabetic, gradually yearly, low risk, medium risk, high risk, whom to do, whom not to do, what frequency it has to be done. That itself, through the guidance itself, there is no evidence that this may definitely bring up some solution for the first ulcer. So with this, reaching to the patient itself with a proper knowledge that insensate feet is the priority and you are not going to appreciate any kind of pricks, and all these painful conditions of the diabetic neuropathy, they have their rural remedies. One is hot fermentation, second, massage, third, applying oil ointments, which have ended up with necrotizing fasciitis. This is a basic thing what rural people do. I had a lot of pain, so I asked my grandchild to stand on my feet, which is a very common in India, where the grandfather wants his children to stand on the feet and thoda ragad do. And he felt very comfortable. The next day, the pressure, what he hasn't appreciated at all, the skin ended up with blebs and necrotizing fasciitis. Many have applied all liniments, varieties of things. See, there are so many issues to be addressed, but the basic thing is awareness at the grassroots level to prevent the first ulcer. And we have an infrastructure where we are not working down the lane to the ASHA care, a healthcare inspector, and THC medical officers, which major concern, which is leading to higher references to the tertiary care centers. They can prevent, at least at initial stages, they can bring up some good knowledge and patient care with local, where I have been working with local leaders of the Gram Panchayats, local school teachers. Most of the villagers listen to the school teachers, which I keep on engaging some kind of awareness program with the school teachers. That has made a big difference.
Yeah, so I think only two questions to be further answered. One is with emerging technology like temperature monitoring devices, smart insoles, and AI-based risk prediction tools. What innovations are most promising for preventing the first diabetic foot ulcer?
Sir, as I told
Anyone?
you very clearly, where there is a neuropathy, as long as you walk, you are going to break the feet. That's a very straightaway answer. So you want to walk how many steps per day? If it is low risk, how many steps you are going to walk? Low risk minimum, that as you put it, very low risk, grade 0. You don't have LOPS, you don't have PVD. So you are allowed. There is no increase of temperature at all. The moment you come into grade 1, then there is neuropathy or you have a PVD. So in neuropathy, as you walk, then you are going to have heat up. That area, some area where there is going to be a excess pressure getting loaded, that is going to have an increased temperature, that you have to record it with the normal. And if you are having something 2 degree extra, then you have to take a rest so that that area doesn't break. So any foot, it heats up first, then it breaks. So that recording of the temperature came up in the field, but how many are recording? It's practically impossible that people have to sit and record after they have 5,000 steps or 10,000 steps, and every day evening they have to check for any change in color, as sir was telling, Sandip sir was telling. Now the next comes wearables. There are so many wearables which have come up where they give you immediate signals to your mobile and say that now this area is going to break. There is a lot of heat getting generated in your foot. Please reduce the number of steps or take rest. All these, are they possible for our villagers to buy and wear it? They are unable to wear even footwear. So these are going to be something different era. I am looking at how best we can bring up education. Now today, the same story was there with heart attack in 1980s when I was an MBBS student. But today, the same farmer comes to me with heart attack and asks me all the details of research. Have you given the injection of 10,000? When are you going to do this? And when? How much I have to pay for this? Whether it is balloon, whether it is stent, whether it is bypass. He is well aware of that research. Means we need to reach to them where the reach has stopped. So reaching to the villager, reaching to the poor farmer makes a big difference.
Yes, sir, I think
I
we
think
have
Dr. N.K.
already.
Singh, we can conclude. Dr. N.K.
Yeah,
Singh,
we
we
are
can conclude.
concluding.
Thank you
This is
so
very
much.
important.
Yeah, we are
Important. No,
concluding.
no, there is one important question. One important question. I think that can conclude the whole session of today's topic. If you could implement only 3 interventions in a busy diabetic clinic to prevent the first diabetic foot ulcer, what would they be and why? Dr. Kari, this will be the
So this
concluding
question
remark
will be the
from you.
take-home message from all of our moderators. So first, I will tell Madam Aarathy to tell you about this. What is your take-home message with the 3 interventions in your clinic?
So I would like to say, look, feel, test, educate. That is what I follow here. So always a simple monofilament with a tuning fork is surely going, and also inspection of the feet and the footwear. That's the first thing I do in my clinic here, sir. So that's going to be very useful to detect.
Yeah, so Dr. Sandip, you are there? The 3 interventions. Unmute yourself, yeah.
Yes, sir. The 3 interventions are, first is awareness. Definitely awareness has the upper hand. And then self-examination. Patients should be taught how to self-examine the foot. And third is proper footwear with socks. So these 3 are to be practiced.
Great. So I think then I will ask Dr. Modi to tell his 3 interventions. Already doing some interventions. So Dr. Modi.
Sir, I always keep diabetic education on top. And for this, we can display some. Number 2, they must be explained the painless nature of this disease, and they must be explained that God's greatest gift to mankind is pain. And once pain is lost, we can see if there is heart attack but no pain. So similar thing happens with a diabetic foot. The third thing, I tell them very forcibly that your small wound will become a large wound, and one day you will lose your legs. To my patient, so they can understand the severity of this problem. That is very important to tell them, because they say this is normal, because we have seen the foot is really, it is a silent foot. It looks normal. So identifying those high risk foot is very important, and that can be done by the clinic doing some other simple palpation of distal peripheral pulse. So this intervention I do in my clinic.
Great. So Dr. Patni, can you propose a vote of thanks and conclude?
Thank you all. I think so excellent. Moderation by our 3 moderators, and I think one of the best speakers speaking on the relevant topic today, Dr. Kari. Thank you all for this excellent session. Dr. N.K. Singh for taking out this particular topic as one of the discussion point. Dr. N.K. Singh, thank you, and I thank you, Pratik, as well, and the team for conducting it so well. So thank you all. Have a nice time. Good night.
Thank you.
Bye.
Good night.
Thank you so much.
Good night to you all. Great.
Thank you, sir.